peer-to-peer webinar. Today we're going to be talking about using learning collaboratives to share knowledge and adopt best practices. So we're really excited today about our panel presentation and for the discussion that we will have later on. Next slide. Just a reminder, this has been a wonderful webinar series. This is our last webinar. And it is a typical format of a 25-minute panel presentation followed by a facilitated peer discussion. So thanks everyone for joining this last session with us. So our agenda for today, we're going to spend 5 minutes, just a quick introduction to who we are, and we'd like to get to know all of you. And then we'll move into a panel discussion and we'll have some time for smaller group discussion. And then if there's time at the end, we'll also bring it back to a large group for some sharing on maybe what we talked about in those small groups. Okay, so just a bit of an introduction. We are the 6 Building Blocks program and team. My name is Ashley Johnson and I'm a practice facilitator and research scientist, and I'm joined by my colleagues, Dr. Michael Parchman and Dr. Laura Baldwin, as well as Brooke Ek and Sharon Garrett. And we are very excited to bring this topic to you and help facilitate these small group discussions as well as the panel discussion. And if you'd like to learn more about our program for improved opioid management and primary care, please feel free to visit our website, which is improvingopioidcare.org. Now we'd like to learn about all of you and where you're joining from. So we've typically used the annotate feature in Zoom. It's kind of a fun way to have a visual representation of where everyone is joining from. So if you could go to the top of your screen where it says view options, and then scroll down to where it says annotate, click on that, and then select a stamp, which will then allow you to select the location that you're joining from. And then also, once you've done that and found those stamps, please feel free in the chat to list your name, your role, and your organization. So looks like we have some over on the East Coast, New Jersey, some in Florida, someone in Arkansas, some over here in Washington, North Carolina, Maryland, and Delaware. Looks like wonderful. And please feel free in the chat to list your name and organization too. Excellent. Oh, someone joining from Alaska, looks like. All right, welcome everyone. Well, this is exciting, have quite the spread here. So we'll go ahead and move on. On our next slide, I'm gonna pass it over to Michael, who's gonna give us an introduction to learning collaboratives and then introduce our panel presentation for today.
Great. Thanks so much, Ashley. And thank you all for joining us today. I know that it's in the middle of the summer and most of us have other things on our minds besides yet another Zoom meeting. Over the last year and a half, we've been participating in many of these. And so thanks for joining us today. You know, this topic really came up early on when we were planning these webinars for the recipients of the OD2A grants from the CDC. And it emerged actually from sort of our needs assessment. We sort of reached out to a lot of OD2A programs across the country to find out what they were doing and what their challenges were and what they were interested in doing. And the idea of using a learning collaborative to roll out a program within your state surfaced several times in that evaluation. And so I thought it would help to begin with just defining, or at least throwing out a definition, it's not the only one, of a learning collaborative. Learning collaborative, that word, that term, learning collaborative, gets thrown around a lot these days, especially in healthcare. But they're also used across public health initiatives. They're used in the educational setting a lot. So public school teachers form learning collaboratives so they can learn from each other, for example. So the definition we pulled was one from an early article trying to get our arms around the concept of a learning collaborative, which is it's something that brings together groups of practitioners, in this case from different healthcare organizations, but it could be from different schools. It could be from different county health departments. It could be from different syringe exchange programs across the state. It could be a number of different individuals. But the idea is that they work together in a structured way with the goal of improving some aspect of the quality of the service they deliver. It involves them in a series of meetings to learn about best practice in the area chosen, about quality methods and exchange of ideas, and a sharing of experiences to make changes in their own local setting. So can we go to the next slide? I think the key behind the concept of a learning collaborative is that learning is a natural human activity. I mean, we all learn, whether we want to or not. We're always learning something new. And in fact, learning is a collaborative activity. It is inspired by our social connectedness. We learn from each other. And it's that social activity of learning that is the real hallmark of what a true learning collaborative is. It leverages and supports that peer-to-peer learning, right? I mean, an expert can come in and talk to me all day long about what a best practice is, and I can sit there and with my arms crossed say, yes, but you don't live in my shoes. You don't work in my setting. But if I have a peer, someone who is like me, who is in a similar setting doing exactly the same kind of work I'm doing, that has more authenticity to me, that voice of hearing from that peer about, well, here's how I solved that challenge. Here's how I overcame that barrier. So it's usually a combination, or it can be a combination of both that peer-to-peer exchange and bringing in outside experts who can add evidence to the conversation about, say, research findings or expertise. So can we go to the next slide? So we're going to talk with a panel this morning of 3 individuals that we've invited. Thank you very much for joining us to discuss the concept of a learning collaborative. And I'm going to attempt to introduce them, but if any of them want to jump in and add anything to the introduction, you're welcome to do so as well. So in no certain order, I'm going to introduce our panelists. Sarah Shoemaker-Hunt is a PhD and pharmacist. She works with Apton Associates, and she is an implementation scientist. And she not only conducts research, but she has provided support on opioid prescribing and management, opioid misuse and abuse, medication management, safety, and quality improvement across a number of projects that have been funded by AHRQ, the CDC, other agencies, including projects on how to implement and evaluate opioid prescribing practices in health systems. But most relevant to our conversation today, she recently led an opioid QI collaborative of healthcare systems to implement the CDC opioid prescribing guidelines and to measure their progress. And I think she also brings, a unique perspective about evaluating learning collaboratives, because she's been involved in kind of thinking about how to evaluate the effectiveness or the effect of a learning collaborative. So thank you, Sarah, for joining us. The next panelist is Alyssa Kittless. Alyssa, am I saying that right? Is it Kittless?
Yep, perfect.
Great. Alyssa is the Community Overdose Prevention Coordinator for the North Carolina Division of Public Health's Injury and Violence Prevention Branch. What I like about Alyssa is her courage in leading the North Carolina Safer Syringe Initiative, which supports their registered syringe services programs, which we know can be a daunting challenge in some settings. but she coordinates the technical assistance that's provided to community-based organizations and local health departments about overdose prevention and harm reduction. And I'm really interested in that, in the fact that she's convened this opioid action plan advisory group, which is a group of individuals with lived experience with drug use, or who work at these syringe service programs. And that advisory group informs the priorities of the division that she works in, which I think is an incredibly valuable and insightful way to go about doing this work. And last but not least, I want to introduce to you Jesse Bennett. Jesse works as the executive director for the North Carolina Harm Reduction Coalition. He is a former drug user and formerly incarcerated person who participates in the implementation of harm reduction interventions, public health strategies, drug policy transformation, and justice reform in his state of North Carolina. And he does that through a unique combination, I think, of leadership, advocacy, development of resources and thinking about policy, and education in every setting he touches. I find it remarkable that he does this because he comes at this after completing a master's in social work from North Carolina State University and is certified in integrating harm reduction psychotherapy, which I think provides a unique lens to some of the work he does. So Jesse, thank you for joining our panel today. Did any of you want to add anything to the introductions that I've just given?
No, that was amazing.
Well, you guys are amazing. All of you are amazing. So thank you for joining. So let's start off with a question about, think about a collaborative, a learning collaborative that you've participated in your work. How did it start? And what was the objective of the learning collaborative and who participated? So could you just say, sort of tell the story, once upon a time, how did it start? What was its objectives and who are the participants? Jesse, can I start with you? Would that be okay?
Sure, yeah, that's fine with me. Can you hear me okay?
You're a little fake. Can you get closer to the microphone?
Yeah. So how our learning collaborative started is, North Carolina is a bit unique in the sense that our syringe service program, or the law behind it, is really low threshold and states that anybody can start an exchange. All they have to do is say they're doing it and then register with the state. And so we were working with the Injury and Violence Prevention Branch and Alyssa and in her space. And basically how this started is because community-based orgs, traditional harm reduction orgs, were doing this work. And we knew that, health departments and other entities would want to come in and as well and do the work. And so instead of, kind of saying that we do this work this way, you do it that way, we felt that we could both learn from each other, or, bringing folks who are subject matter experts into the fray. And so, initially it was community-based orgs and a small amount of health departments. And it has grown into kind of a split. And we tried to do it where we do, western part of the state, one quarter, middle part of the state, then eastern part. So everybody would at least have a chance to join.
Oh, you're muted, Michael.
Once again. Alyssa, do you want to comment on the same question about your experience with learning collaboratives? Sort of what was the objective and who were the participants and how did it start?
Yeah, and I'll talk about our learning collaborative as well. And so I joined after the collaborative had been formed, but really something I found in bringing folks together and coming into the role of helping convene it with Jesse and his team at NCHRC is that the learning collaborative, the objective, absolutely is what you spoke to, the peer-based learning opportunities to bring in experts to hear from each other, have discussions, troubleshoot challenges and hear best practices. But really, another really important goal that I've seen in our Learning Collaborative is that building community. In North Carolina, we have, as of now, just about 41 registered student service programs. It's going to be probably a few more here soon. And they're working all over the state. So there might be a county where they have a few different folks that they work with, or they might be the only person doing this work. And it can feel really isolating, and you might not know how to approach certain things. And so the Learning Collaborative has been a really incredible space to just know that you're not alone. You have the support. When this used to happen in person, we'd have things like cookouts and really build that connection on the individual level, as well as create that space for learning. And, in that, and we'll talk a little bit more about additional TA, but it's really the starting place and the connector. These meetings are a really good opportunity to come together, but it's a good way where if you're dealing with a challenge, you know exactly who to call, Lauren in Charlotte, because you met her at this meeting. And so really, I think that's been one of the biggest values. And what I see as like our main objective now moving forward is just creating that space for community and learning.
Yeah, I love that. I every time I've been in a learning collaborative, when I hear about some participant who contacted another participant with a challenge or a question, I just do a little happy dance. It's like, okay, this learning collaborative has been successful. That's exactly what we wanted to have happen. Sarah, how about your experience with the learning collaborative approach that you took it with the recent work you did on the CDC opioid prescribing guidelines?
Sure. Just briefly, and we'll probably get into some more details as we move along, but we supported two different cohorts, we call them the Opioid Quality Improvement Collaborative, which we enlisted or recruited 5 to 6 different relatively large healthcare systems from across the country to participate. The first one began in 2018. The second cohort began in 2019. So the first one ran about 3 years and the second one ran about 2 years. And the aim of it was for them to be part of a collaborative for their health system to identify what recommendations within the CDC guideline for prescribing opioids their system wanted to pursue or aligned with their patients' needs or clinicians' needs in addressing this issue. So that was really their charge on a kind of individualized basis. And then we had a set of measures or metrics to help monitor some of those recommendations over time. So they would capture those or produce those measures for their own monitoring, but then also share those with us and then participate on at least monthly implementation calls. And we pursued some kind of clinical webinars in the first cohort that we ended up not sustaining. We can share insights from that, but we would do kind of mixed implementation calls where sometimes we'd address specific topics that we either knew from kind of one-on-ones with each of the individual health systems about what they were encountering or what they could use more insights about from their collaborators, and usually spend about 15-20 minutes, either bringing somebody in externally or someone on our team to talk about a specific issue such as tapering or planned care visits or things like that. So that was generally the structure, and I can share more as we go along, unless there's something else, Michael, I should share at this point.
No, that's great. Let me just follow up on the comment you just made about this, which is how did the struggle between presenting new information, sort of the didactic presentation of information versus allowing space and time for the participants to discuss and interact and to learn from each other. That ratio is oftentimes a moving target. It's difficult to hit. How did you play with that? How did you process that through the experience of both cohorts of the Learning Collaborative?
Yeah, I think it kind of evolved what we learned or what we thought. Admittedly, the first cohort was probably more advanced in where they were at with addressing this issue in their health systems compared to the second. So that was a different setup. And when we tried clinical webinars, like very clinically focused, it would only work if there was actual clinicians involved. Whereas the people we were often working with were maybe they were a clinician part-time, but their role might've been more in a quality improvement, or they were an expert focused on this issue within an academic health setting, or they were clinical psychologists. So usually these were people that were kind of the champions that we were connecting with on a regular basis. So the clinical focus was kind of less relevant, at least we found for this group, and it's hard to get clinicians availability, right? So the balance was that we sometimes at the beginning would try to cover some important topics in the beginning of the collaborative, but as it went on, it was most important just to connect monthly and regularly.
And did you have meetings monthly?
Yes, at least monthly as a whole group. And then we did, in the second cohort, we found a liaison model was a little more helpful or productive, where we had an individual liaison matched with each health system to have a more in-depth understanding of their unique needs. And then we'd sometimes bring those back to the group, such as we had somebody come in and talk about motivational interviewing, and they talked to their clinician group and like scheduled that separate call. So we kind of shared that experience in case other health systems wouldn't really even think to ask for that type of assistance, that, you know, if this is something your system could use, your clinicians, we would gladly offer that.
So you had two touch points, the monthly group meetings and then the monthly one-on-one touch base call with a liaison individual to do a deeper dive into what their needs were. Jesse, how about you and Alyssa, in terms of the structure of your collaborative? How did it get set up, and how did it evolve over time, and what are you doing now?
I mean, initially it was a lot of community-based orgs, and then as health departments started to come online, you know, it kind of started to be split and even. Prior to COVID, the goal was to have, you know, folks would come in a day before and we'd have community, right? Have cookouts and things like that. And then have the meeting where, you know, somebody would come in and do, you know, a talk about voting rights, or, you know, another org would come in and, you know, have a conversation around another thing, right? And so that would be part of the learning side. And then we would, you know, have a kind of group discussion around any issues or policies that were coming up, and, you know, how to address those. And then, you know, as COVID kind of kicked in, we had to adjust. And, you know, I think it was kind of a learning process through the process of COVID. And, you know, having breakout rooms within the Zoom was interesting. I think people's natural tendency when they come on Zoom meetings is to just want to listen to someone tell them stuff. So getting more interaction or one-on-one or kind of intimate talk that we would have in person wasn't, we kind of lost that during the COVID process.
Alyssa, any thoughts about the structure of the Learning Collaborative in terms of the frequency, the duration of the meetings, the topics, the opportunity for discussion versus presentations?
Yeah, and Jesse spoke to this a bit, but as he mentioned in the beginning, when we were having them in person, they would be longer meetings. So usually from about 9:30 or 10 to 2. As we moved to Zoom, we shortened them to about 2 hours, just because that's, you know, we're all really zoomed out, and our learning community or collaborative is part of a larger TA model that we do. So both the North Carolina Harm Reduction Coalition and our team at the Injury and Violence Prevention Branch do a lot of individual TA. We also have some quarterly calls with some other more health department focused communities. And so, you know, some people are on many of those groups. So it's that balance of wanting to connect frequently and create those connections and cover topics, but not wanting to overwhelm people. So quarterly is about where we've landed. You know, I think there is value to meeting more often, but just given the work that everyone has on their plate, especially because certain service programs have been frontline responders during COVID and have been so busy throughout that. So I think the biggest thing that's helped us in the structure in moving to the virtual space is just being flexible, because, you know, we just want to recognize that people have a lot going on. And then really something that's been important in the structure for both the in-person and the virtual is just being responsive to what our participants are asking for. And so we, you know, I was going to talk about this later, but our general evaluations, more process evaluation, and in all of our after meeting, we asked about topics that are coming up. And we also talk to this group pretty regularly. You mentioned our advisory group, that a lot of folks, there's overlap. So we're hearing often from community partners, and Jesse and his team keep us well informed about some of the topics that we should cover. So we try to make sure that we're bringing in like the most pressing need. For example, our most recent one was on polysubstance use, since we're seeing increasing trends, multiple substances involved in overdoses in North Carolina. And then we try to balance it about half and half, where we do half presentation, half discussion, just because, as Jesse mentioned, it's hard to have that more individual level or group discussion virtually. And we've been doing some breakout rooms, but we found that the presentation sparked some of that conversation and provide that groundwork for launching off points, because there's so much to cover and trying to really focus on those priority areas that we want to cover in the meetings. And then in the questions that you all sent beforehand, you asked about support, but the nice thing about this model for us is that it's a little different than a more traditional clinical learning collaborative, where we don't necessarily have the same people at every meeting. We have, generally core group of people who will come, but we have a lot of fluctuation, which we appreciate because we really want to like build the bench or umbrella in the community. But in that, we don't necessarily have to do as much follow-up to make sure the same people are there every time. So it's usually myself and Jesse, or one or two staff person planning the meeting, and so it's not incredibly labor intensive, but it does provide that space to connect. And then the only other thing I wanted to mention was just that this is part of a range of other technical assistants, and so not only do we hope that these meetings will create peer interaction and learning, but if there's a follow-up item like a webinar topic that comes up, that is coming up a lot through these conversations, we'll create additional learning opportunities, or even create a resource, or connect folks to Jesse's team or some of my colleagues who are TA technical assistance leads. And so it's a launching point where we can have that peer-based learning, but there are a lot of other opportunities to engage and support programs if they're struggling on a particular area, such as centering lived experience or evaluation. We tend to connect them with more direct technical assistance.
So this brings up a really good issue, which is oftentimes people want a place they can go in between meetings. Did you create a virtual space or a place where people could go to either post questions or interact, or to access resources that were added to the Learning Collaborative? Was there a virtual space for that?
Yeah, so that was one of the other things that I mentioned, is we have a listserv where we connect with folks, we share, and it's more like one directional. It's not as bi-directional as I would want, but it's, we share out opportunities and learning, and that is something we played around with. So another similar model to the Learning Collaborative is we do a harm reduction training called our Harm Reduction Academy. And for that, we use Slack to try to share some of those resources. And because people are kind of apped out, people didn't use it as much as possible. Yeah. So honestly, for our Learning Collaborative, we just use a Google shared folder where we put resources and things like that. And that seems to actually work more because people have not wanted another thing to log into. So we've been playing around with other things, and I'm curious what folks do, but we do try to, we talk regularly and we share information out and have conversation, but we don't necessarily have a virtual platform because that doesn't seem like something our collaborative wants right now.
Sarah, how about your group in terms of staffing and support for this, and then the whole issue of creating resources or a shared place? What was your experience with that?
A couple things, and just kind of drawing a parallel to the North Carolina group's learning collaboratives. I think, so we were dealing with, health systems from different states across the country. So we actually, thankfully, were able to connect in person, which we thought was kind of important to build just rapport. And then we always conducted everything virtually from then on, even before the pandemic. And we did have a house kind of website that had a lot of resources around different components of the recommendations within the guideline, or example treatment agreements, tapering resources, things like that. So we did have like a website where these things were housed. Admittedly, people were pretty mixed in terms of the extent of use, and we certainly I don't think it occurred that people used it to like share or discuss. I think we had set it up. It didn't go anywhere, but we still had things come up, usually within the monthly calls with the group. When they shared things, somebody would be like, would you be willing to share that? Could I reach out to you about that? Like there was usually some type of communication. They would just do direct emailing. We didn't even have a listserv. It wasn't really that large as far as how many individuals were kind of involved. But we did have that website, but the use was not extensive. And lots of people also didn't use it, some better than others. It just seemed to be somewhat individualized, but so we kind of balanced how many resources we put into that type of thing. But there's sometimes value in just some things being housed in one place, because when people do ask or think about it, they're like, oh, I think they mentioned some things, so they would go to it. But yeah. And the staffing resources, the liaison model was what we definitely did in the second cohort, which we thought was important. And I think it probably depends on kind of who the participants are and where they're at, in what stage, and what the aims are. So we had health systems which are probably doing more diverse different things to kind of improve practice, as maybe compared to some of the groups in the Learning Collaborative in North Carolina, like that had kind of a very specific, similar aims. So I think sometimes the sharing would be not as directly relevant, but kind of just broadly relevant. And our charge and hope was really kind of to just help them improve for themselves, like within their own aims of where they were at and what they could do to move their own needle, not set some other needle that somebody else makes up arbitrarily. So
Yeah. Jesse, were you about to say something earlier? Did I cut you off?
I think I forgot. I think I was just trying to build off of Alyssa's, what she was saying around our learning collaborative. Usually towards the end, we try to figure out what other topics folks want to hear about, and try to address the needs of the group versus trying to guess or assume what we think Western North Carolina needs versus Eastern. And the polysubstance use is one. Wound care is a big one. A lot of outreach folks are having to do wound care in the streets, and just general care around people who use drugs, and just trying to advance more than just giving out syringes every day.
Right. And just a last question for everyone. How do you know your learning collaborative was successful? We sort of touched on this earlier when I mentioned I do my happy dance, but are there other indicators that you look for to say, yes, we're doing okay, or in terms of evaluation, or maybe we need to make an adjustment here, an adjustment there? How do you evaluate or measure success of a learning collaborative?
People come back next time.
They keep showing up.
Yeah.
And also Jesse's gonna laugh, but our folks are really honest. So, we ask, we have process evaluations, and they'll tell us. Like at first coming to this role, I thought, will people be open to me? But I've learned that they're very honest. And so if they don't like something or want to see something more, they'll tell us. So yeah, we do some, like counting of participant numbers and tracking of all those things and do the evaluation. But yeah, our folks will show up and they'll tell us how it's going.
Great. Sarah, any thoughts?
Yeah, I would add, I think, people showing up, it's an important part of it. I think I've probably learned a lot about what I would expect or what I think makes it seem successful, but I think participation, and I think, for us, I think, the second cohort we spent through COVID. So the extent to which those health systems, got as far along with their own quality improvement efforts around this issue within their health system was limited and affected by COVID. And so we pivoted to address that. But so I think kind of just our orientation in the collaborative was valuable. Like they appreciated that we didn't just act like this wasn't happening and that they needed to focus on that. And what does that mean for the care they're providing, and what's really the priority around the patients on long-term opioid therapy and safely managing them. So I think that pivoting and kind of being with them and the realities of what they were going through. And I think, it turned out in the end, all that besides being a researcher and wanting good data and things like that, I don't know if I had super high expectations of what would come out of it, but what we got out of it in terms of formal data wasn't as clean, robust, or easy for them, let alone for us to get to. So, but I think my real aim was for them to be kind of launched in their own QI efforts to continue it forward from the point of the collaborative, since they were ending at some point. So to set them on a path to kind of continuously improve in this care of these patients and safely.
Right. We have about 1 minute left, and I just want to just circle back to the three of you and say, is there any burning lesson learned that you want to share with this group? Anything that you feel like I think the group really needs to know this about participating in a learning collaborative. Anyone have something they want to?
I do. Just one thing that we asked, our systems to reflect on the experience for them being part of the learning collaborative. And I think the piece that was probably the number one value to them was the kind of accountability. So the idea of being a part of a community that, really didn't have any, they didn't have any ownership to be responsive. It wasn't anything legally mandated that they, achieve what they should achieve. So I think it was just the accountability of coming together and checking in. And we didn't, you know, it wasn't punitive if they didn't achieve, like, it's been a rough couple months or what, it just is. And it was just these updates, but it was the accountability. I think several of them thought that was the real benefit, was this opportunity. And then second, I think, was the shared learning, but I think first was accountability for the groups we worked with.
I would agree. I'd agree with that too. The accountability and community for sure.
Mm-hmm.
Right.
Yeah.
Alyssa, any last?
Well, it's more in convening, and we spoke to this, but I think the flexibility. So this is not the first learning collaborative I planned, and just having the space to have your goals in mind and support folks in their goals and their accountability, but also be responsive to Sarah, and we mentioned the COVID, just making sure to change and address what people are going through there, but also as things are working and as you're identifying needs. I think it's nice to have a framework and a structure, but be able to be flexible and create a space that is going to be most beneficial to your participants. And then I think just creating opportunities for regular input, because we get a lot of good feedback from folks, and we're able to adapt and improve what we're doing, make the meeting a little shorter if folks are tired, and because we really don't want to plan a meeting that's not going to be helpful or beneficial. And so just that space to adapt as folks are giving you input.
Jesse, Sarah, Alyssa, you people are jewels, you're diamonds. You're awesome. I just want to say a word of thank you. I think we need to wind up here to give us an opportunity to do a couple of small group breakouts. But thank you for taking time out of your very busy schedules in the middle of the summer to do this. Thank you for your comments. Thank you for your wisdom. So I'm going to pass the baton, I think, back to Ashley.
Or Brooke. Hello.
Oh, Brooke. Oh, hi, Brooke. I didn't know you were there.
I'm very sneaky.
You are sneaky.
So I am introducing our breakout sessions, which will be a little bit like a tiny mini learning collaborative right here on this call, where we're going to experiment with what folks like Alyssa were saying about how it's a little harder to get people to participate on Zoom in breakouts. So I am giving you all a goal to see if we can change that. So during our breakout sessions, what we're really hoping is that you guys will feel like you're having a productive discussion that can lead to some learning that you can bring back to your state and the work that you're doing. We really, like these guys are talking about with learning collaboratives, just want this to be useful for people. We're hoping that we'll be able to develop ideas with one another that we can share with a larger group. So we'll be putting together a key learnings document that we'll send out after the session so you can take those learnings with you. So on the next slide, it talks about what we're going to do in the breakout sessions. And yeah, went a couple slides too far forward there, but I have the questions, so I can tell you anyway. Oh, there they are. So these are the discussion questions that we would like to talk about in our small groups. So one is just whether or not you've participated or used a learning collaborative in the past, and what was it for, and what worked well, what would you do differently? And how did you evaluate its success? Also, if you've experienced unofficial learning collaboratives, as I know I have, with the 6 building blocks, we did shared learning calls, which was sort of an unofficial learning collaborative. So I'm looking forward to hearing if you've been a part of those. And what was it about that experience that made it effective or ineffective? And then are there areas where you think a learning collaborative could be useful for you and in your field? And we'd like to hear a little bit more about that and what you learned from the panel that you might be able to apply to that work. So I think we're going to be breaking, this is a small group, it is summer today, so I think we're going to be breaking into 2 groups. So when you get that notice, go ahead and accept it. We'll see you on the other side.
All right, welcome back everyone. I hope we all had some great discussion in our small groups. I know the group that I was a part of, we definitely did, and made some great connections. I'm curious if anyone wants to go off mute and just briefly share what you guys discussed in your groups. And feel free to also list those in the chat if you're shy or don't want to come off mute.
Well, we were torn away in the middle of discussing a brilliant idea, which is having multiple collaborative partners to organize a learning collaborative. So the university, a state agency, a community-based organization. But having those partners meet as sort of a planning group or a planning committee, a steering committee to help organize the Learning Collaborative. So that was one idea that was shared.
It's a great idea.
And I might take that moment to finish the one train of thought I had there too was you were asking about steering committees, and we have one between us at the State Health Department and the university partner at UNC IPRIC. But there's another group of experts that we have, kind of like a group of subject matter consultants, and they were used more early on in the process to help conceptualize the ideas. And if we have something a little bit more thorough review or a document or something that requires more big picture thinking, then we still have them kind of on tap to help drive the work too.
Wonderful. Others?
Ina, would you be willing to just share a word or two about what you learned in the Learning Collaborative or in our small group session?
Oh, you're on mute, Ina.
Okay, sorry, my screen looks funky for some reason. So yes, in our small group discussion, we were talking about a learning collaborative charter or agreement letters or MOUs that oftentimes are necessary to get that buy-in from the stakeholders. So we were discussing templates or resources around that. And I am from Baltimore County evaluation team, and we had people from different states who also expressed interest in, who indicated that we kind of like had a small TA session in the breakout session, and we shared information. We'll reach out after the meeting and get in touch and maybe learn from each other that way.
Yeah, that's great. Thank you so much. And I think what we also learned is that, some learning collaboratives, it's perfect to have like a partnership agreement letter or an MOU, and others, like the North Carolina one, doesn't have that appropriately because it's a different kind of group in which they're really trying to be open to everyone, regardless of how much they participate or what their, what their level of interest is. So you want to kind of gauge that and decide whether to use that based on the collaborative you're creating.
Excellent. Thank you both for sharing. It looks like Amy threw another idea in the chat here with the link with some additional resources. Excellent. Well, we will compile these great ideas and send out a document with all of them. And on our next slide, let's see if we have our evaluation. So we would love to hear your feedback on how the session was, and it's a very short 2-question survey. So please, in the last minute here, take some time to fill that out for us. But again, thank you everyone for joining us. I know it's summer, but we really appreciate our discussion that we had, and thank you to our panelists for making the time to be with us here today. So with that, everyone, thank you again and have a great rest of your day.
Great. Thank you, everyone.
Bye.
Bye. Be well.
That was fantastic.
Yeah.
Thank you for the
Thank
opportunity.
you. No, thank you for joining.
Yeah, happy to. Really appreciate it.
Yep. Bye, everybody.
Thanks,
Bye.
everybody. Bye-bye.